Okay,
All right.
I'll start the recording, and now I'll have to make you the host, I think, so we can okay, Mary, you're the host now, so you should be able to share your screen again. Okay. All right, part 2 of Dr. Mary Paiva and adolescent health.
Okay. All right. Yes. So we talked about behaviors resulting in risk taking and versus chronic medical conditions as children transition from childhood to adolescence. So we know that in a healthy population of adolescents, a lot of the media portrays adolescents as lazy. In PNG, they're often referred to as the boombox generation. Sometimes they're referred to as narcissistic, and all those are negative connotations that are placed on adolescents. But now that we know what we know, that the brain is developing from the back to the front, and the higher executive function of the brain is the last to develop, we can now have a little bit more empathy to our dealing with adolescents in the healthy population. So our roles as caregivers and parents and educators, if there are any educators online today, is to prevent risky behaviors from developing into serious medical conditions later in life, to promote some of those risky behaviors, because not all risks result in negative consequences. And we make it look like the adolescent period is filled with risk-taking and negative consequences, but there are also some positive consequences of risk-taking as well. Such as an adolescent will take risks to, the rewarding system part of the brain allows them to look for opportunities in novelties and challenges. So they challenge themselves to new ideas and new skills that adults would most probably not take, given the fully developed prefrontal cortex. And in our care for adolescents, we also need to protect them. We need to guide them. And we also need to create safety nets so that those risk-taking happen within safe spaces. So adolescents, as we know, many of them are too full to care. And many of them rely, as they establish independence from parents and caregivers, many of them look for peers in society, and they have social interactions with their peers mainly. And peer pressure has been shown, studies have shown that when an adolescent, when a young person, when a teenager is given a challenging task to do on his or her own without the presence of peers, there's usually some restrictions or limitations to those tasks if it's a challenging or new task. In the presence of peers, it drives risk-taking. So so peer pressure is, if you have to look at it in a negative light, also drives young people to taking risks more than if young people didn't have a lot of peer pressures in society. And as we know, healthy young people will not access social services in communities because in PNG, there are not many social services in communities. And young people do not feel the need to get to look for any other services except to find it in their peers. So with risky behaviors, negative risky behaviors and recklessness results in increased health risks in adolescents. In the sick population of adolescents, where the management is usually of medical conditions, we have hospital wards in PNG where it's an open Nightingale ward, and it adolescents don't have the privacy when they're placed amongst young children in the wards, and being placed in adult medical wards is also a daunting experience for adolescents. They also have fear of stigma and discrimination, and early transitioning from pediatric services to adult care services needs to be curtailed to the developmental needs of adolescents. So when we talk about risky behaviors, this is when the brain doesn't know the difference between good experiences and bad experiences, and it's just plastic in response to all experiences. So this is when there is a tendency for higher incidences of motor vehicle accidents, violence and trauma, unintended pregnancies result in higher risk for HIV and sexual transmittable infections, and intimate partner violence. Substance abuse, studies have shown that if drugs, especially illicit drugs like marijuana and cocaine and amphetamine, exposure to these drugs before the age of 15 is 7 to 10 times more likely to lead to addiction and substance abuse later in adulthood. And peer pressure causes a lot of that negative risk-taking. In adolescence as well, I've put mental health burden here as a risk as well. So if you have a child coming through into the period of adolescence, and if they have higher risk of developing any of the mental health issues, at least 50% of them will develop it at the age of 14, more girls than boys. And by the time they are 24, 25, 75% of them will have developed some mental health burden. So as we see, as more children are surviving beyond 10 years of their life from medical conditions, what we're seeing is that there are more survivors coming into adolescence and less thrivers leaving adolescence into adulthood. And adolescents with chronic medical conditions, they have some elements of prefrontal cortex stunting. The myelination is not fully established. Synaptic pruning is not fully established, and therefore you have reduced or delayed neuromaturation as they reach adulthood services. And this is an issue in transitioning of care from pediatric services to adult services. And that is why we need to tailor, we need to do a case by case of each child that we see in our care, in our services, that when they are transitioning into adulthood, that their medical case tailored to their developmental need before they get into the adult medical services. And many times we have parents and caregivers, or even health workers and support staff who have a paternalistic approach in what they think adolescents should do in their lives in terms of their health care and their health plans. But we also need to know that this is the time when they are they want to establish independence from authority. And so we need to give them autonomy to make decisions about their own care and management. So successful transitioning is really associated with improved health outcomes and quality of life. If we're not successful in the transition of care, it may lead to worsening chronic disease control. And therefore, the onus is on medical providers, family members, and adolescent patients. And we all need to play a critical role in implementing and executing a plan for successful transition of care. So how does that look like in PNG settings? This is a proposal of what it could look like. So if the pediatricians take on the honors of developing adolescent units in their own hospitals, we can have probably establish a non-psychiatric service first of all, so that the psychiatric care is shifted away from other clinical care, and you have the surgeons who can contribute to the care of adolescents in a segregated adolescent unit. You have physicians who can do that. provide the same care. You can have obstetricians and gynecologists to also provide the same care in adolescent units, but the onus should be, we feel that the pediatrician should take on that role. And we can also work with social services, peer support groups from schools and communities. Churches do a lot of work in terms of reproductive health and trauma in the young people. They can also get involved. NGOs, there are so many donor partners and non-government organizations that work in isolation, and roles can be duplicated. So if we have adolescent units in hospitals, everybody does the same work, and roles and programs are not duplicated. And most importantly, schools need to be involved in. If there is an adolescent unit in the hospital, in hospitals where children are not able to go to schools, schools can also come to them where they are. So at the community level in PNG, currently there is a government entity called the National Youth Development Authority, and they're creating adolescent hubs within communities, mostly around Port Moresby. In the provinces, you would have the departments of community development, and these hubs or these one-stop shops could be places where the healthy population of adolescents can access in terms of their social services. So these are young people in the community that may want to learn new skills, life skills training. They may want to get information on mental health and basic care, or sexual and reproductive health that is at their, it's accessible to them. They could also volunteer in these programs, and it makes a referral pathway, strengthens referral pathways between schools and communities and hospitals, and can also provide counseling services through those adolescent hubs in communities. And then you can also have involvement of other partners as well. So this presentation, we have come to the end of the presentation. So these are some things that we thought we could all probably look at and see how we can all contribute to improving, to ensure that our adolescents are thriving in society. Currently, there is a technical officer position or adolescent health coordinator position at the Department of Health in Papua New Guinea, but it's probably not fully functional. So to have adolescents with behavioral issues, or to ensure that positive risk taking is happening in the right places, to ensure that there is guidance and programs are fully established and coordinated and collaborated well, and there are links and networks in the sectors of society, we need to establish a position, a very strong position at the Department of Health to be able to handle all of these issues of adolescents. Secondly, we can't get any person, any health worker to work in the adolescent units of the hospitals that we are proposing to set up. The health workers that work in the adolescent units, they need to respect the unique privacy needs of adolescents. They must have experience in providing as much autonomy despite the dependent states of adolescents. They must have empathy, and they must have a non-judgmental approach to working with adolescents in the hospitals and in the communities. As more and more research is being done over the development of adolescents, we need hospitals, whether in PNG or Solomon Islands or Vanuatu or wherever you are, to consider training, specialized training of pediatricians to support and coordinate adolescent health programs at the national level. Currently, the HPV vaccine has not been introduced yet in PNG, and we are hoping that within the lifespan of the Child and Adolescent Health Policy and Plan 2021 to 2030, that this is introduced and schools can be able to implement it in or wherever they are. And finally, and not the least important, is the legal framework around adolescent health. It's archaic. Many of the legal issues are archaic, they're draconian, and they need clarification and possible amendment to that. With that, thank you so much, everybody, for listening.
Well, Mary, thank you very much for taking the time to give us this talk today. I mean, it was a wonderful presentation of neurobiology and adolescent development and the legal framework and programmatic approaches. That was really, really good. So thank you very much for taking the time to do that. We do have some time if anybody's got any questions. Mary's raised a lot of issues and you might have some questions for Dr. Paiva. If you have them, please ask. Mary, I wanted to ask about, you said that there was not too many marketing strategies that were targeted towards adolescent development, but actually there seem to be a lot of marketing strategies that are targeted towards adolescents that function in many ways in a negative way, and they're very commercially driven. How can adolescents really deal with the new things that are put to them, like like social media and the potential for bullying and all those things that happen to adolescents in the modern era? How can we help them do that?
Thank you, Prof. A lot of the marketing strategies that are happening around adolescent health and well-being come in the form of health education at school levels, basically health awareness. And if you have a very excitatory arousal system, the rewarding system in the brain, which will only go after whatever it thinks is rewarding and whatever it thinks is exciting, that's a part of the brain that will seek out what's in the environment that's good for the adolescent. So there are some positive risk taking that can also sort of hone or prepare the prefrontal cortex to full maturation. And some of those, they're really basic things. Some of that is sleep. How many adolescents do we know have at least 8 to 9 hours of sleep? But at least 9 hours of sleep is what's recommended. If you have an adolescent who is on the phone, who is having at least 5 hours of sleep every night, and they swear they won't do it again the next night, but they still do it, it increases their risk it increases levels of frustration, it increases levels of unhealthy eating and emotional lability in young people. So sleep is one of the positive measures of prefrontal cortex maturity that are being recommended. One of the other things that's being recommended for prefrontal cortex maturation during that period is active sports, being able to be participating in active sports. So a lot of the programs, I'm not sure. I mean, my daughter is only 10 and she doesn't do any kind of, there's no established physical education in her school. So that's one of the important things that children need to participate in before they get into adolescence, is be able to participate in at least 30 minutes to an hour of active sport. And that also increases synaptic pruning and allows, reduces risk-taking behaviors when the prefrontal cortex is in maturation. And the other thing that reduces prefrontal maturation in children is exposure to artificial light. So exposure to things like smartphones, light emanating from smartphones, from the TV, from the laptop. It tricks the brain to thinking that there is still light around, there is still ambient light in the environment, and that reduces sleep patterns in children, and that also reduces prefrontal cortex maturation in adolescents. So social media, I mean, scrolling through social media, passive scrolling, is also an issue with prefrontal cortex stunting in a few studies that have shown. So as much as possible during the periods of 13 to 16, preferably, children are very social beings. the amygdala is well developed during that time. They're very social beings. They want to have social interaction. If not with their parents and family, it's with their peers. And that's what we need to kind of encourage in young people. If they're going to be on their phones, they have to be actively using their phones. They have to be texting their friends, they have to be talking on their phones, but not passively on their phones, scrolling up and down. It does nothing for synaptic pruning in adolescents. So health education is probably not as a rewarding concept in schools, but other things like sleep, sports, and meditation. A lot of children who go to church have very good decision-making skills. They have good judgment of right and wrong. They can plan better. So if you have a teen who is in church, encourage the young child to be in church. If a teen is not in church, encourage meditation or yoga or those sorts of things.
Okay, thanks, Mary. Questions come through regarding the amount of screen time that's safe for adolescents. Do you have an opinion about that? And how can parents help their teenagers deal with limiting screen time? Do you have a view on that?
I don't have any, I haven't cited any studies relating to that, but what the studies that I was referring to in terms of artificial light emanating from phones and screens and laptops is that they say as soon as the sun sets, ensure that there is enough screen time for an adolescent child and a young person, so that they don't confuse artificial light as still ambient light from environment, and they continue to stay up late into the night. I was going to say something about that, but now it's just completely just gone off my mind.
That's okay. Another question's come through regarding authority to make medical decisions for adolescents at different ages, and particularly in the setting when something is potentially life-threatening. So the authority to consent or refuse medical decision-making. Do you have a view on that, about that level of competence? Can you say something about that, Mary? Yes,
we shouldn't be afraid to give autonomy to young people. We should work with young people to ensure that the level of trust is first and foremost there, so that when it comes to decisions like in very high level environmental stresses, like a life-threatening medical condition that they have to undergo, you already have that trust that's already placed there between caregivers and parents and adolescents. So if a young person trusts his or her parents to take ownership of medical decisions for him and her, that decision is very easy to make. In a setting where young people don't feel safe, they don't feel secure because of triggers in society that propel them to make decisions on their own and be less trusting of adults, they won't give that autonomy very freely to adults. So we need to be mindful first and foremost that, the adolescents, they are also part of our society, and we need to work together with them. We don't give them full autonomy, but we also work with them to ensure that that autonomy is shared and it's accepted.
Thanks, Mary. There's a concept in some centres of what's called Gillick competence, where a person is competent, can be assessed to be competent to make medical decisions on their own if they're emotionally and intellectually mature enough. I guess that's something we could
yes.
look at. Yeah. Okay, well, there was one other question I had, a question really regarding the issue of sport that you mentioned. I suppose we're not talking necessarily, competitive sport is not for every adolescent, is it? And what we're talking about is healthy physical activity in some way, but it could be art, or it could be music, or it could be language, or cooking, or craft, or just catching up with friends, anything that's healthy and physical outside their home or their studies. Is that what you mean, Mary?
Yes, exactly. Because young people, they look for novelty and challenges all the time. So when we're talking about competitive sports, it's only given to a minority group of people, a minority group of young people who have the benefit of competitive sports. So when we're looking at enhancing full development of the brain, it's the novelties and the challenges that we can give to young people so that they continuously seek out new changes in society, new challenges, and they can challenge themselves to be better than they were the last time. And that also increases, neuromaturation in young people.
Okay, well, look, thank you, Mary, for a wonderful talk and a good discussion today on adolescent health. And I think all those who watched both parts to this talk will have learnt a lot, and we've recorded the session. So for those who missed some of it, we'll be able to look later. But thank you for taking the time to do this, especially after recovering from an illness in the last couple of weeks. We really appreciate you doing this, Mary. So thank you. And good afternoon.
You're most welcome.
Yeah. Well, goodbye to everyone.
Thank you.
Right. Bye now.